Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about audit trends in home health and hospice. And now I'd like to introduce our industry guests for this episode. We have OC Board Secretary Robert Markette, JD, CHC, HCS-C, attorney with Hall, Render, Killian, Heath, and Lyman, PC on the call today. Bob focuses his practice on representing home health, hospice, and private duty providers in all aspects of their operations. With more than 10 years of experience in working with these industries, Bob has developed a reputation for understanding the issues facing home care providers and has assisted clients in a number of areas related to the operation of their businesses. And we also have Claudia Baker, RN, MHA, HCS-D, HCS-O, OC board member and senior manager with SimiTree on the call today. Claudia has 35 years of healthcare experience in the areas of compliance integrity, quality improvement, and managing regional and corporate operations. Thanks for joining us today, Bob and Claudia.
Well, thanks for having us.
Thank you.
Oh, always a pleasure. Let's kick things off with an audience poll. All right. Our question for you all today is, which of the following questions for claim denials do you have the most trouble with in your organization? And our answer options are securing compliant face-to-face documentation, securing clinical documentation that supports medical necessity, securing clinician documentation that supports the need for therapy, and documentation that doesn't support hospice eligibility, or other. Please choose one answer, and if you answer other, please share the comments that tell us a little bit more about other in the question pane. All right, folks are still voting, so I'm going to give it another second or two before I close this out, and then we will discuss the results of this poll a little bit later in this call. All right, it looks like things are slowing down, so I'm going to go ahead and close that poll. And let's get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many of them as we can. Bob and Claudia, I'm going to turn things over to you. Just let me know when you'd like me to advance to each of the next slides, and I will try to find my mouse here and get us to the first slide. There you go.
All right, so I will kick things off with a brief discussion of well, I mean, it will be brief, home health denials, and some thoughts on how to avoid some of these common denials. We have a limited amount of time to cover what I think is a relatively large amount of information, so we're going to kind of hit the high points. But I wanted to start to help everyone see what we're dealing with and why we're focusing on the particular topics we are, as we kind of briefly go over some home health documentation issues. The data we're getting from CGS and Palmetto related to home health denials and the reasons they're saying in their data they're denying claims or audits or otherwise. And you'll see here on this first slide. So this is CGS's data. Now you'll note it is today, tax day, April 15th, 2024. So congratulations, everyone. This data is from August of 23. Their data does not get updated very frequently. So the most current data, when I put these slides together, the most current data you could access on their website was through August. So the current data, if we could access it, might be slightly different. But my experience over the last several years has been these issues, it's kind of like survey data, right? You see the survey data within the top 10 findings, the top 10 might reorder, but generally the same things pop up. And so here with these denial reasons, we see the number of reasons for services being denied with skilled nursing services not medically necessary, which is interesting because that's an actual review of the documentation to determine medical necessity. Usually what we see in most quarters, or what do you want to call it, the number one denial reasons are technical. They like to, see this in the second one, initial certification, missing, incomplete, invalid was 20%. Face-to-face encounter, missing, incomplete, untimely, 18%. They like to knock out those technical requirements, because if I can knock out the certification, I can knock out the face-to-face, then I'm done. If I'm an auditor, no certification or incomplete certification, invalid certification, close the file, mark the whole thing recovered, because that disqualifies the entire episode, move on to the next chart. It's much more efficient for them, and it lets them get the entire episode. With skilled nursing services, they're actually going to look at the records to determine the medical necessity of the service. So it's a bit more intensive. So it's interesting to see that one move all the way up to number 1 in this slice of data. And then number 4, we see documentation did not show therapy services were reasonable and necessary and at a level of complexity requiring a therapist. What's interesting about that is with PDGM, we stopped receiving the therapy bonus payments for crossing thresholds. Therapy used to be a really big area of auditor focus because they would try to knock you below the thresholds to take back that therapy bonus payment. With the therapy bonus payments going away, now we just get the flat episode, yet we still see a focus on therapy, even though the financial incentive to overutilize therapy, which we were alleged to have been doing, was taken away. The auditors continue to look at therapy, in part because, as with nursing visits, if I can knock those visits out and move I may be able to take out the entire episode, but if I can move the number of billed visits down below the loop threshold, I can still take back a lot of money, because it reverts you then to the loop of payment for the episode, the visits that remain, instead of the entire episode. And then last, and I'm going to go through these and then the next slide's data, and then we'll discuss a couple of key issues that are documented, but I want to set the framework first. And finally, we see that medical records are not received in the 45-day time limit was a denial for 4% of the cases. What that means is they didn't get them. Now, does that mean the agency failed to respond? Did they get lost in the system somewhere? It doesn't really say, but in 4% of cases, they didn't get the records timely. And if they don't receive the records, they just deny claims. So if you don't get the records turned in to an auditor, they will recoup everything. And sometimes then, because at that point they determine it's an easy target, they will come back for more, because they can, if you're going to just fail to respond, they can just keep taking money back. And Medicare is a little short on cash right now, and they're looking for any reason to take money back. In fact, that's a lot of the audit process. Is simply a retroactive rate reduction, because every visit I can take back, every episode I can take back means overall your average episodic payment goes down. So then, if you want to advance to the next slide, Jan. So here we see Palmetto's denial reasons. What's really interesting here is the number one reason for Palmetto denials is records not submitted. And if you think about the CGS one we just looked at, it was a 4% denial rate for lack of records. Palmetto's at almost 42% as of September of 23, which means it's running 10 times higher. And so the question that raises is there a problem with agencies within Palmetto's jurisdiction, or is there a problem with Palmetto's process where something's breaking down? Because that's a significant disparity between CGS and Palmetto when you go from 4% to 42%. Then for Palmetto, we see face-to-face, 27%, no plan of care certification, 12.6%. So those two are similar to CGS. The order is reversed, but we're still seeing close to 40% denials based upon face-to-face and the plan of care certification issues. Then medical necessities, 2.3%. Now they just state medical necessity for the service generally. They don't differentiate. They don't talk about nursing, et cetera. They come down to therapy. I put down here an additional after number 5 because you had to go down farther into it and combine a couple of categories to get to 3.8% for lack of therapy medical necessity. So 4 is likely the nursing lack of medical necessity. And then we see something different here. They couldn't determine necessity from OASIS because OASIS is in the state repository. So that comes up to 2.5% of the time for Palmetto. It wasn't cited in the top 5 for CGS, which is another interesting disparity, because that again an issue of providers, and I've seen this happen with providers where the EMR is not properly submitting oasis, and they don't find out until later. But I've seen other cases where we have proof the oasis was submitted, but it doesn't show up in the state repository for some reason. So it's another potentially technological disconnect. But we see it for Palmetto 2.5% of the cases. We don't see it for CGS. We also see a low number of lack of physician's orders for services cited by Palmetto as well. So we see a lot of commonality between the two issues, between the two auditors, Palmetto and CGS. The biggest, a couple of big takeaways or provides as we're thinking about audits and being prepared for audits and ADRs. The fact that I believe the Palmetto audit denial at 42% is probably a process issue on Palmetto's side with things getting lost, but it comes up in the top 5 both for Palmetto and CGS. And so it's important to be sure you have a process for responding to ADRs. I've had clients, in fact, I've got one going on right now. It's with a state Medicaid audit, but it's the same problem, and that is an audit letter came in and the person who received the letter didn't know what it was and didn't do anything with it. So you need to have a very specific process for receiving ADR letters, making sure they go to the right person, making sure your deadlines get calendared, the documents get produced. And these days, the production is generally electronic through a portal. But if you forget about it, if you lose it, if there's no follow-up on your end, they will simply deny the claims. And you may find that your first awareness of the audit is when you get the claims denial later because you didn't respond. And I would also note, you can get extensions. If you don't think you get the documents pulled together in the time frame, the auditor can grant an extension. But it is incumbent upon you, the provider, to reach out to the auditor, request that extension, and get the extension in writing. Because if later there's a discussion or any kind of dispute about whether or not you were timely, it will be up to you to prove that you did in fact get the extension. So that's just the broader process in general. But then you come back to the two big substantive issues. I guess I say 3: face-to-face, certification, and medical necessity. We are now, 12 years into face-to-face, and it continues to be the #1, basically, denial reason for audits. The auditors continue to focus on face-to-face. They get us for things like we didn't have the physician's order, we've missed the technical requirements. You've got to be sure you're getting the face-to-face information. You get questions about, is the face-to-face encounter related to the reason for home health? And you'll see auditors will be looking for a one-to-one correspondence between the physician's codes and your codes, which is not supported by the guidance provided by CMS. So it's important to remember you can supplement the physician's record. There's a process. It's clearly outlined in the Milliman Matters article that is still, I think, kind of the article on this topic. And so you can do that to make sure the face-to-face does in fact support the claim. The plans of care certification issue, a lot of that comes back to signatures and timing. Making sure you get the signatures, making sure that the certification has the correct magic words in it, because if the certification doesn't have the magic words, if it's not signed before you send the claims, things like that. If you failed to get the verbal order and the verbal certification, and was it locator 23 on the 45, when the nurse signs and dates that he or she got the order from the physician, if you don't have those things, you're gonna have a gap. And so you've got to make sure all those technical requirements are met. Otherwise, again, they'll knock it out. And then lastly, I'll just do this very briefly and then hand off to Claudia to talk about hospice. Medical necessity. Your staff needs to understand and make clear in the records, why are we providing these services? Why does the patient need this care at this time? And it's not just at the time we admit them. We need to be making the case in the record throughout the episode or episodes to support the medical necessity of services, because we see here now, the auditors are looking more and more at medical necessity. And if our documentation doesn't make, if I see this all the time, we get used to it. We get, whether it's EMR or whatever, our documentation starts to look the same. It doesn't make the case. It's just, it's Mrs. Smith. We know her. We do the same things over and over. And we fail to include key details to explain the medical necessity. You really have to be looking at that and on your staff about making sure you're painting the picture of medical necessity every time you go out to see the patient. It's important for billing. I say this when I do classes on nursing professionalism. it's important for patient care. If something happens to you, if you're the nurse caring for the patient and you're not writing everything down and then you can't make it to work, or heaven forbid, you're in a car accident or something, how does the rest of the agency know what's going on with this patient if you haven't taken care to provide thorough documentation of the care provided, the medical necessity, et cetera? Because you might not be there. So it's not just about the billing, it's about patient care. It's about establishing the record for everyone else on the team, what's going on. And I know we're in a hurry. I know the EMR makes it simple just to check the boxes. I know that we all get familiar with the patients. We've seen that in many audits I've done, but we have to be better because we're looking at this more and more. And with that, so as to leave Claudia enough time, I will stop talking and hand off to Claudia to discuss hospice.
Thanks, Bob.
Yeah, thank you, Bob. I can reiterate a certain amount of what Bob said as well. So we're going to start here with the hospice denials, and this is the CGS information. And I agree with him. It's interesting to me that the information not supporting the terminal prognosis of the 6 months or less piece being number one is just a little bit of a surprise, because it is very easy for them to go with an election not being there timely, the face-to-face not being there like it's done. Those types of things that are technical denials are much easier for them to just knock out quickly and send your denial on and move on. But yet the number one really is about the terminal prognosis, which means they've done the chart audit, they've looked at it, they've studied it across the time, they've looked at the patient's trajectory, and based on the diagnosis, based on the LCDs, all those kinds of things, and looked at the chart and really found that it was lacking. So that being number one with CGS, I think is significant in the same way. These elections really have to be, there are many requirements on it, and they can't be understated. Most of it, with the exception of the addendum, has not changed for a long time, but yet we still don't seem to be getting that piece right. Make sure that your notice of election meets everything it's supposed to, that it's really got all the pieces and components that are required to it, but it's very, very date sensitive, right? So, I mean, you've got to make sure that you've got the right date of the time that the patient or the family or POA, whoever elected the benefit, you've got to make sure that that is correct, that if they have their attending, they do that. If you have to create an addendum with it, that you've done that timely as well. So all of that are the statutory and regulatory requirements on that that notice of election. That's 40% of challenges right there. That's almost half of what they can just very quickly knock out. Face-to-face encounter requirements not being met is a smaller number, but significant as well. Again, because we're looking at the top 5 denials for CGS. And with CGS, a similar pattern as with the home health, medical records not being received or not being received timely is still an issue with CGS, but you'll see that it's more of an issue from the Palmetto side of things as well. So we'll take a look at that. Jan, you can go on to the next slide. Okay, so in looking at the Palmetto data, again, the patient not being appropriate for hospice, which means that's the same number one reason that we saw on the other slide, right? They just worded it a little bit differently with Palmetto for whatever reason. So again, establishing hospice eligibility, making sure that it is documented from beginning to end, make sure that you've got objective measures in there, make sure that you've got every single thing that they're asking you to do in the LCDs as much as possible about this patient, right? Because that's the core of what hospice is built on, right? I mean, making sure that we've got all the decline in the patient status, make sure we've got the exact symptoms and signs of the condition that's going on. What are the comorbidities for these people? And how do they significantly play into that? All of that, again, to use Bob's words, it's not just a write it at the beginning and then we don't put it down anymore. ongoing, every note, every time, every IDG, every time you have a discussion, every time you research this patient throughout their course with hospice, we have to support all that documentation every time. And I get it. I mean, I'm a nurse. I've been there on that other side, and it's hard to do that all the time, and it not just be those check boxes or just the simple, easy way out in our documentation, time after time after time. I have done so many chart audits in my life that do nothing but, it looks like I wouldn't know if I was looking at a patient from today or whether that same patient's note from 9 months ago. And we just can't do that. We have to really make sure that we are proving that this patient is hospice appropriate throughout the documentation, through again, our scoring, your KPS or PPS, whatever you're using there, but then each one of the objective measures that go with whatever, you know, your primary and the other diagnoses go with it as well. Making sure there's, you know, if you've got infections going on, if you've got wounds going on, if you've got anything like that, changes, are they more dependent in ADLs? We can't just say that the patient's needs more help with ADLs, and you have to write in what way, right? You have to actually define what that means. Were they dependent in 4 of 6 ADLs, and what are those 4 that they were dependent in before, and what are they dependent in now, right? Because every bit of that, and I know how hard that is to do. I get it. And with GMR, you have certainly can help or maybe even hinder you sometimes in making sure all that's captured. But regardless of what software you're using, it's up to us, right? It's up to us as the hospice. It's up to us as the individual clinicians to make sure that we get all of that in. That's my soapbox for the discussion here today. Is certainly on clinical documentation. But the other reasons sort of follow suit. Again, that election not being in there. The records not being submitted timely is 17% on this side with Palmetto. I think the number for home health was like 41%. So this one's not quite as bad, but there is that discrepancy there between the 17% here with the Palmetto group and only 3% in the CGS group. So that could be a number of reasons there, and I agree with everything Bob said. Again, face-to-face, making sure, and then that initial certification not being done timely. We've got very clear timeframes on when all of these, everything that we do just about needs to be signed, when it can be done, what time frame it's got to be done in, and again, most of it hasn't changed in a while. We just struggle to meet that at times. Those are the easy denials. Those are those technical things that they can just look at, check out some dates, and then send on your denial. So make sure, you know, try extra hard, make sure your policies and your plans and your processes are in place to get those things done timely, for sure.
Thanks, Claudia. I think we have one more kind of wrap-up slide.
Bob, you want this one?
Yeah, I mean, sure. And I think feel free to chime in as well, because I think you probably have some thoughts here. But like I said during the home health section, face-to-face still is our big issue. Like at this point, I don't think face-to-face was originally sold as an anti-fraud tool. I think at this point it's simply kept around for purposes of clawing back money, because it's a terrible fraud tool. If I'm going to commit fraud, I'm going to fake the face-to-face, and I'm going to hit all the elements. So a fraudster's face-to-face is going to be compliant, period, end of story. So it just gets the rest of us. The other one, though, is the physician documentation. We are relying upon the physician for face-to-face, for certifications in home health, for certifications in hospice, for narratives in hospice. And one of the ongoing struggles providers that I work with deal with is getting the physicians to complete their documentation, especially now that you've started to see auditors, we're starting to see whistleblowers arguing that the physician's signatures need to be back within the episode on the home health. Like you've got to have it back in 30 days or 60 days. That's not actually stated anywhere, the manual says you just have to have the signatures before you bill, and there's several DAB appeals opinions where the ALJ has said that the physician's later signature relates back to the nurse's date of the verbal order, but they're really hammering that now because they want you to work faster. Well, we are at the physician's mercy, and so one of the things I talk to clients all the time is having a process to repeatedly but gently follow up with the physician, right? There's a fine line between getting the signatures and alienating a referral source, but we want to be careful to make sure we're working to get those things back, because what's really frustrating is the physician documentation can be a survey issue as well. I've had that come up in surveys where we're having trouble getting signatures. One of my favorites was during the pandemic when it was taking months to get signatures, and we said to the surveyors, the physicians are all at home now, right? Like, this is a pandemic and things are different, but it still ended up with a conditional finding. And so we really want to focus on what's our process there for physicians, getting physician documentation, making sure it's complete. Because remember, the physicians are trained to document, et cetera, to support their claims. They're not thinking about necessarily terminal illness or home health. I mean, perhaps more so the terminal illness side, because our medical directors, our hospice physicians, they ought to know it. Although, as Claudia pointed out, they don't always, and that's where we have to educate them as well. But we really need to be working to make sure we have complete documents. They understand what goes into it. And like I said, on the home health side, we can supplement the record. We can send stuff back to them, segments from the OASIS, other information, because they're not thinking about, is the patient homebound? By that, remember the homebound test, they changed it several years back to make it more difficult to meet in terms of audits, et cetera. So you want to make sure you've got those processes in place to make sure you're getting that documentation, make sure the physician is doing things correctly, making sure that when you can supplement, correct, et cetera, you're doing that, because making sure you have the other things, simple things like the actual encounter note for face-to-face. Did you get it? You'll need it for the audit. It's a requirement. And then did you check to make sure that it's related to? All those types of issues are all part of our ongoing compliance process that we do up front, so we avoid all the issues on the backside. And Claudia, if you have anything to add to that, feel free.
No, I could do a whole OC talk just on physician narratives and hospice, but we'll defer that to another day. Jan, if you want to wrap up.
Oops, I'm making a note. Thanks, Claudia.
Suggesting.
Yes,
Yeah,
yes. Thanks to both
Claudia,
of
you just volunteered.
Yeah.
Fabulous. I love it. Let me just quickly share our poll results, because I think they do go in line with what we were just talking about. So we asked, which of the following reasons for claim denials do you have the most trouble with in your organization? And face-to-face was the top issue, followed by clinical documentation that supports. So definitely goes hand in hand with what you were just sharing. And you gave a lot of great pointers about how to try to educate and supplement and get good face-to-face documentation. So thanks to both of you. Any thoughts about those poll results?
Yeah, I'm not surprised at them at all. It pretty much is how I would have expected the poll to go, unfortunately.
Yeah.
It's like Groundhog Day. Like we've been doing the same thing over and over and over, and we just keep ending up in the same spot.
Yeah, it's frustrating for everyone.
Oh, yeah. Well, thanks so much. Lots of good information there today, Bob and Claudia. I really appreciate you joining us for the call today. And I have just a few more things to share. I'm going to move on to what's new with OC, where we share updates from the Association of Home Care Coding and Compliance. And I just want to remind folks on the call, if you hold a Board of Medical Specialty certification, we are doing our credential holder survey right now. It's still live, and we do want to know what your certification means to you and how we can better serve you. So please follow the link in the handouts to take this year's survey and share your thoughts. And if you haven't downloaded the handouts yet as part of the live call, you can always find them on the OC website shortly after the call. They'll be under resources, free webinars. So hop on over and download those handouts if you need them. And I also wanted to make sure that you know, if you're interested in learning more about compliant face-to-face documentation, Decision Health's Face-to-Face Answers, which is put together by OC Board Chair Sharon Harder, is a great resource. This book provides a rundown of how face-to-face encounters have evolved for home health and hospice and provides clarity around the rules as currently written. It also serves as a reference for agency teams, detailing how the rules and interpretive guidance should be applied on a day-to-day basis to ensure compliance and retention of reimbursement for services provided. And this month you can get 15% off the Face-to-Face Answers Guide at the Decision Health store with coupon code F2F15. So if you're interested in learning more about compliant face-to-face, this is really a great resource. And I want to say we hope you enjoyed this episode of OC Talk. Thanks again to Bob and Claudia for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our next call on May 20, when members of the OC board will be discussing recent survey guidance updates. And in the meantime, if you'd like to re-listen to this episode or to a previous one on the go, you can find OC Talk on your favorite podcast app. If you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. Thanks again, Bob and Claudia, and we'll see you all next month. Take care.
Thank you.